right, well, we'll get started then. We're just waiting for Tom Dodd to join us, but I think we'll get started at this point in time. So welcome everyone to our COVID-19 update for GPs and for any clinicians, practice managers, practice staff around what's happening here in the state in terms of our COVID-19 response. So first of all, I'd like to acknowledge the land in which we're meeting here today. I'm here on Kaurna land, and to pay our respects to elders past, present and emerging. So thank you very much for joining us this evening. First of all, a big thank you to all of the key partners, and particularly Adelaide PHN and to Crystal Myers. They have been doing a phenomenal job getting out masks to practices and also alcohol gel, noting we've had a lot of changes come in the past week with the mask usage requirements. So a big thank you to Adelaide PHN, then to SA Health, SA Pathology, AMA SA and RACGP, all who are very kindly contributing to tonight's webinar. So we've got 4 of us here this evening. Hopefully Tom will be joining us in a tick. I haven't seen his name pop up yet, but we've got, first of all, we have Professor Katina Denisi, who's our Executive Director of Prevention and Population Health and also Executive Director of the CDCB COVID system, so working across 2 sites, doing a phenomenal job, Katina. And then we have Dr. Tom Dodd from SA Pathology, who's just joined us now. I'll just promote you, Tom, to a panelist there. And Dr. Chris Moy, AMA SA President and Vice President of AMA nationally. And of course, we've heard a lot of Chris lately. You've done a lot of media lately, Chris. So we're looking forward to hearing an update from you. And then finally, myself here from SA Health as Deputy Chief Public Health Officer and also Deputy Chair of the RACGP here in SA&NT. And I'll be facilitating the question and answers. So please post questions that you have. Hopefully we'll be able to get through all of those with our expert panelists this evening. So first of all, I'll go to, so please post any questions. And then first of all, we'll go to a parafield cluster update from you, Katina, if you're happy to give us a quick update where we're up to here in the state.
Hi, Emily and everybody. It's good to be with you this evening. Well, I guess the good news is that we haven't had any new cases for some time. And from a communicable disease control perspective, this we would consider day 13. So you might know that really we like to see 28 days free of any COVID infections to feel somewhat confident that the outbreak is over. So we've nearly hit the halfway mark, which we're very pleased about. One of the things though, which I know we've discussed a couple of times already, is testing. Our testing rates in South Australia are very low, in fact, somewhat lower than we were pre-outbreak. I just want to check that others can hear me because I've just seen a note that one person can't.
No, I can hear you, Katina.
Good. No, that's fine. I'll keep going. Yes, I would have to say that the level of testing is worryingly low. For us really to be confident, you know, when we get to our 28 days of no cases, that in fact the outbreak is over, we really need to know that we've got enough people being tested. You can have, of course, undetected chains of transmission that go on for some time until the virus reaches somebody who goes and gets tested, or in fact people just get very sick and end up in hospital. So really that's the biggest kind of drive now, is to make sure people are tested. In the meantime, in CDCB, we're putting in a lot of work learning from what we have or what we've learnt through this outbreak cluster, and I guess what it took and the scale of the quarantine that we were required to do. So we're of course continuing to learn, adapt our systems, make them stronger. So we will be stronger now in our response because of it, but we of course hope never to have to use it again. That's all from me, unless there are any specific questions.
Thanks, Katina, for the update. So well done. 0 cases today, 0 active cases now. So that's fantastic news. You're at day 13. Look, I think that the testing numbers are something we are very concerned about. And I know, Tom, you've got a slide around the testing numbers coming up. So I'll show that as well, just to demonstrate how concerning it is. I know we've talked before, Katina, around aiming for that 8,500 level for testing on a daily basis. I think that's helpful, I think, for people to understand, particularly for us GPs, to understand why it's so important to get higher testing numbers.
So, I mean, really, this is kind of looking for a needle in a haystack, if you like. One individual case undetected can lead, well, frankly, to the Victorian level outbreak. We know that's exactly how that happened. There are some models that have been done, and, you know, models always have their limitations, but that look at our probability of picking up a case over a week, depending on the population size you have and your testing rate. And what we've worked out is that during events like this, we need to be in South Australia up around the 8,500 cases, tests done a week, in order for us to have an 80% chance of picking up a handful of cases. Now, I just did see a question about asymptomatic testing. That is not what we're interested in, actually. So thank you for bringing that up. In reality, we need people who are symptomatic, even with the very mildest of symptoms, to be tested. So we do know that that sits around the 5 or 6% of the population. So it isn't actually very common, these sorts of symptoms. But if you extrapolate that out to the population, it's actually quite easy to test 8,500 or thereabouts on a daily basis. I think I might have said weekly before. It's meant to be daily, if I did say that.
Thanks, Katina. That's very helpful. And I've just put up there around the daily new cases as well. You can see that spike there. You can see our international arrivals brewing along there, and then that big spike just around the 14th, 15th, 16th of November there. And then, of course, we're probably going to be expecting more overseas arrivals testing positive as well, Katina, now that we've started getting flights back. Is that what's expected from your perspective?
It is, and we had a flight in with just over 90 people, I believe, today. What we were seeing up until we had the outbreak was around 3 to 4% of our incoming arrivals being positive. I guess we would expect that to be climbing slowly. So, you know, we could predict around the 5% mark going forward.
Thanks, Katina. And Chris is just, we've seen Chris on Twitter, and he's going to post his Twitter link there. I've just seen you posted to us, Chris, around making the point regarding the need to test. So I'll share that in a minute on the screen. You can see here now that cases in SA, the active versus recovered cases, and of course, no cases today here in SA. So that lovely blue line you can see on the screen, but of course, expecting more red up as we see the international arrivals coming back into SA. Thanks, Katina, for that update. I'll hand over now to Tom to give us an update on where things are at with the testing. Of course, we've just heard about those low testing numbers, but it'd be great to talk through particularly where our 12,477 tests, which is a phenomenal effort.
So, yeah, thank you, Emily, and good evening, everyone. So, look, obviously the case for testing has been made repeatedly, and Katina's just spoken about that. But what I really wanted to emphasise to everyone tonight is the laboratory's capacity now to do large volumes of testing. Back in March and April, we were, cautious about how many tests we could really achieve in a day. South Australia got through up to about 19,000 tests on the day. We did 12,500, and as you can see, the numbers have dropped and dropped and dropped. Obviously, people immediately come out and want appropriately to be tested as soon as there's anything happening out there in the community. But what very rapidly complacency comes back in again, and as you can see over the last few days, we've really dropped away. And I guess with the general opening up of the community and the easing of restrictions, people are going to feel increasingly confident and complacent. So our responsibility is to actively encourage anyone with symptoms to be tested. Everyone knows this, but remind you, obviously, that the presentation of the patient from Parafield actually wasn't through routine testing, but through a presentation to an ED department, well, these folk could easily be presenting to a GP with very mild symptoms. So it's critically important that we get that testing rate significantly higher than where we dipped to at 1,500. So we have the capacity now to do really over 10,000 tests a day. People are concerned about the impact of having a test. The turnaround times now have got so good that we had a turnaround time of under 10 hours yesterday for over 90% of our tests. So people can go, present, get a test and have their result back essentially within 24 hours, about 90%, and then get on with their lives. And so the the excuse in inverted commas to not have a test because I'm going to be held up from work or social activities at the moment really doesn't hold out. So you all, I'm sure, will be actively encouraging patients to get tested, even with the most minimal symptoms. I think the challenge now over the next fortnight will be to continue to get that testing done. We're not through that sort of 2 reproductive cycles through, and it would be very nice to see that number sitting much closer to 5,000 or 6,000, ideally 8,500 over the next fortnight. And then as the medical community, we could have a even heightened confidence we will not have something terrible happen on Christmas Eve, which all of us want to avoid vehemently. So rest assured the laboratories have got the capacity and capability to put through vast numbers of tests, and I'll be very pleased to see that happening over the next couple of weeks. So we've just got to see how we go. It's sort of incumbent on all of us to encourage everyone to go off and get a test whenever they present to us.
Thanks, Tom, for that update. We've had a couple of questions coming around asymptomatic testing, and I know, Katina, you've just sort of explained that as well, why we don't want to be testing lots of random asymptomatic individuals. But I guess just in terms of respiratory infections out in the community, you talked through the percentage of people who we know are out of the community based on the Wellbeing SA testing reports that come in surveys. I was just wondering, Katina, if you could just go through that a little bit in terms of, what we're sort of expecting out in the general population in terms of respiratory illness or reporting of acute respiratory symptoms.
Thank you, Ellie. We do a random survey population. At the moment, we are around 300 a week, let's say, and the random is fine. So working the entire time of the pandemic, the sorts of acute respiratory infection symptoms in the community. If we ask in general, we get around 10 to 15% of people report some symptoms. But then if you go to that next question that says, are these new for you? You kind of remove the people who perhaps have chronic cough. And we sit somewhere between really 5 and 10% of the population at any point in time reporting acute respiratory infection symptoms. So even in the outbreak, when we had vast numbers of people in quarantine and we were clearly checking for people's symptomatic status, we basically sat at around the 10% mark across each of our large quarantined groups. So that's a pretty robust finding, I think, that we can say, we don't really drop less than 5% of the population. I was just on my calculator working out the numbers. And I worked out that would be the equivalent, if you basically took it for a week at a time, over 80,000 people would have some sort of respiratory symptom that was new. So it is common. I have seen reports that there's a bit more RSV around than usual, but I don't know, Tom, if we have that in South Australia or if in fact we're doing the panels to pick this up. But we certainly have enough people symptomatic about. Obviously, the amount of COVID infection we would have wouldn't really change those proportions. It really reflects, the typical sorts of acute respiratory infection viral causes. But yes, we certainly have enough people to warrant testing over 5,000 people a day. And that will be still a small proportion of the total number of people who are actually symptomatic.
Thanks, Katina. That's very helpful, I think, for everyone to understand as well, and appreciate that we talk about these high numbers and really we're not even capturing all of those symptomatic individuals we expect out in the community who have those acute symptoms. We've had another question come in around, should healthcare workers be tested on a regular basis? And I know you've been doing a lot of work in this space with active health worker surveillance, but just wondering if you could go through where things are up to, Katina, with healthcare workers seeking asymptomatic testing.
Okay, so we don't actually recommend at this point asymptomatic testing. There's been a lot of studies that have been done looking at how effective asymptomatic testing really in any population is. It's actually, you have to be pretty lucky to pick an infection up either in an asymptomatic individual or pre-symptomatic. There are times when we would consider extending out to asymptomatic testing, and really that's in the midst of a major outbreak. So not even necessarily community transmission, but for example, if you're working in a hospital and there's an outbreak within the hospital setting, that would be an example of a time when we would want to test asymptomatic healthcare workers, with the idea of picking people up, you know, while they're infectious but not yet sick. But otherwise, there's really not very much evidence. I guess one of the things that's difficult about this virus is the level of symptoms that some people have, which are really very mild, which you'd have to call near asymptomatic. But we do find that even with people who say they've really not had any symptoms, you can often isolate, you know, a day when they felt very tired, they had a headache, perhaps a bit of a scratchy throat, but then it passes. So most people, in fact, have some sort of level of symptoms. It's just that it's not necessarily a dramatic illness. And in fact, for the people we've had in this cluster, we really haven't seen people with dramatic illness. Not anyone. Not even our people who were aged in their 80s. Very mild.
Tina, isn't that right? And God forbid, Tom, there's no such thing as a false positive, but isn't the risk in a low prevalent situation of a false positive actually causing a major scare at that point as well? So you suddenly increase the risk in a low prevalent situation?
It's most definitely the case that your positive predictive value relates to the prevalence. We do Tom, obviously, I don't really want to speak for SA Pathology, except for to share my confidence in SA Pathology's ability to identify what looks like a false positive. We've certainly had, over the last 6 months, we've had a handful of false positives. The good news is that we get a very strong sense that that's in fact what they are early, and on repeat testing, we can usually resolve it. But most certainly, I guess they're kind of competing things, aren't they, really, Chris? We're asking people to get people tested in a low prevalence environment, which means that potentially we will see some of these, but we are pretty good at working out when we've got one in front of us, versus the scenario of our first case, which came out of nowhere and we were worried, but none of us thought it was false positive.
So the laboratory strategy to deal with this issue of false positives in a low prevalence environment is to repeat the test across several different platforms. So we have had the experience, as Katina mentioned, of 2 or 3 cases now where you have a positive maybe against 1 of 2 genes on one particular instrument. We then repeat it again on typically 3 completely different platforms which have different targets. And so on that basis, you can really rule in what's definitely a true positive versus a false positive. And in the scenario where there's still doubt, obviously you'll repeat the swab over the next couple of days and do serology as well. So we've got a very high level of confidence that when we call a case positive, it is a true positive.
I think this is all very, very interesting discussion points as well. And we looked at Victoria, I know previously, when they were saying, you didn't need to self-isolate, and perhaps was that a reason and a barrier for people not going and getting tested in the first place? Do you think that's something, Katina and Tom, we should be exploring again, whether we have that requirement to not self-isolate after testing?
I think the really important message for clinicians to get to their patients is that they'll get their result very, very quickly. So many people will have had swabs early on and will have had to wait around for maybe days to get results. So now, typically you'll have a result in under 24 hours and quite often faster than that, particularly in the metropolitan areas. So it's less of a barrier really for people to go and have swabs right now. If someone had a swab, say in May or something, and has got a sort of bad memories of having to wait around for a couple of days, that's not the case now. And if we can reinforce that when you've got symptomatic patients, I think that's very helpful.
Katina, what are your thoughts on that as well around the isolation post-testing for someone who's not been directed to go and get tested and isn't a close contact? Do you think that's a barrier for symptomatic non-testers?
Well, we have in the same survey that I discussed earlier have been asking that very question. So for the people who haven't gone and got tested, we've then asked them what are their main reasons. In fact, a lot of the main reasons relate to I don't think this is COVID, or some other explanation for the symptoms. And then the third one, and they kind of diminish rapidly in order of magnitude, is I don't have time to get a test. So we kind of thought that we would see things like, oh, well, if I got tested and I was positive, I'd have to go into isolation and I can't afford that. In fact, those sorts of things we really haven't seen. So I'm not sure how much of a barrier the isolation, if symptomatic, is. And of course, just in general, we don't want symptomatic people kind of circulating anyway. So from our perspective, we would say people really need to be isolated if they're symptomatic. That's independent of whether they've been tested.
Yeah, I think that's an excellent point. We don't want people out and about. And I noticed there was a comment as well around RSV cases in Murray Bridge as well, that there was a lot of reported cases in that area where the testing wasn't necessarily possible, but certainly the symptoms coming in were conducive with RSV. So thanks, Pete, for posting that.
So I'd just say, Emily, the Gene Expert test, there are cartridges for influenza and RSV if you've got patients presenting, particularly in the regional areas where you are concerned about the possibility of RSV, particularly in a sort of a ED environment, or, you know, someone's reasonably unwell. You can get that done rapidly by your local regional lab as well.
Thanks, Tom. Now, we've had another question come through, which I think this is an excellent question around have we had any suspected reinfection or reactivation here in South Australia? And is there a protocol in place for the diagnosis of reinfection? I think that's an excellent question. So, Tom, I know you've commented previously on this area, and I think Katina as well.
So I suppose the comment I'd make is that we've done whole genome sequencing now on every case. So that potentially could be useful if we had a case in someone who was apparently positive, you know, earlier in the year. Then the genome sequence of the new infection would be helpful to distinguish persistent versus a new infection. But I'll let Katina field the question about whether we have or have not.
I think an easy answer to that question is we're not sure. To be able to identify a reinfection, obviously it's handy if they've got two different genome sequences, but that sort of scenario is pretty rare to see. There are some groups that have proposed a framework for deciding whether a case is a reinfection or basically prolonged shedding or other equivalent explanations. Some people would say that you need to really be at 90 days, and if you've got basically a lot of symptoms that are consistent with COVID infection plus a test positive, that would be consistent with reinfection. I think actually people are not very clear, and also the amount of shedding that people do following a positive test result and the ability to pick it up on PCR is kind of unknown, I think it's fair to say. I guess we have a possibility that we've had a case of reinfection within South Australia, in that it fits that kind of outer limit of what we would expect to be possible with the single infection, but we couldn't really prove it. And I've only ever seen case studies where they've proven it where there's actually genotype difference, like the whole genome sequence is different.
My understanding, Katina, is that there's been less than 30 documented cases across the world, something like that so far. And that, obviously we're still, I think it can occur, that's the agreement that it can occur, but it's actually quite rare. And that like initially we were very much more worried about the immunity, the ability to have sustained immunity from COVID, but it does, the data is starting to look a lot better for that overall. So, it's such a difficult thing with so few of them. That's the problem, isn't it?
It is, but when we have spoken to our New South Wales colleagues about this, because we had to deal with this just before the parafield cluster, and their experience was that they thought that they had seen a few of them. So it's possible that they're more common than we think, but this is all supposition really. None of us, because of the fact that those unusual circumstances where you would be able to prove it are pretty rare.
Thanks, Katina. Thanks, Chris. So we'll go through and talk now through a couple of the other topical issues, the first being mandatory mask usage in healthcare settings. And I know this has been very topical. We've had a lot of emails come through, particularly in our GP inbox and also through other avenues as well. And I'm sure, Chris, you've had a lot of contact as well from your members around the impact of mandatory mask usage in healthcare settings. And of course, that's extended out into residential care as well, and particularly into the disability sector. So it's been an incredible quick shift in events that's happened since last week when this was introduced. So we have seen a bit of a pivot and shift now in how this has played out. So initially we had single mask usage with the surgical mask required in the direction. It was then a grace period was then given for a couple of days to say that this would be reviewed, and the introduction of cloth masks would be noted into the direction. And then finally on Friday night, the direction changed to note that face masks could be used with no specific requirement regarding whether it had to be a surgical mask or a cloth mask, but really that it was up to the clinical setting in which you were using the mask. And I think that is really important to look at with this, that if you are in your GP clinic and you don't routinely wear masks and you don't fit into the PPE matrix for wearing masks, then cloth masks are certainly acceptable in that setting. It has been quite difficult, I know, particularly for practices who haven't had supply of masks. And I know we've heard from many colleagues in other sectors, and particularly in the mental health sector, around the fact that they haven't had any masks I'm scanning over slides there, sorry. They haven't had any masks available for their clients coming in. So it is an important thing for us to reflect on and look at to see, well, what does this mean now for masks going forward? So it was announced today in the press conference after the transition meeting that we would be ceasing the requirement for mandatory mask usage on the 23rd of December. And that was that decision is still being worked through and discussed as to what settings that will apply to. But suffice to say, we expect that'll be across all healthcare settings, provided that there's no evidence of any community transmission. And then it will be up to the individual LHNs and hospitals to decide what their policy will be going forward with mandatory mask usage, whether that's for visitors or clinicians in those healthcare sites. So we are expecting to see that the requirement for mandatory usage will stop on the 23rd of December, and that date was chosen based on Professor Spurrier's advice to the transition committee around that being 28 days from the last case that an individual was in the community. So very happy to explore that further around the masks. I know, Chris, you've been doing so much work in this space, and I'm sure you've got some comments to make.
Look, it was clearly a fair bit of an imposition early in the week, but I can talk generally about it. I mean, the SA Health were very good, and Emily will know I've been in contact with her and many others, including the Minister, to try and sort this out. I think there's been two issues, obviously, just the suddenness of the decision, and then the communication, and just because we've been held up in terms of the final decisions. But look, I know there has been a fair bit, some frustration within with many of us out here, but look, I'd just cut SA Health a bit of a break on this one. It was a little bit messy, but they've been extremely responsive to feedback and direct communications with them. So now it's just a matter of just tying this down and getting it to a common sense level, which is going to be functional.
Thanks, Chris. And of course, the other change that we've seen as well has been the QR codes, and the requirement to have QR codes in healthcare facilities, of course, has caused, drama for many because of the fact that we've had to do COVID safe plans, particularly in general practice. But I think it is really critical. And I'm hoping, Katina, you might be able to comment on this about how important it is to have accurate and reliable information coming into CDCB from a contact tracing perspective, and really what you're hoping to see with these QR codes now being situated within the Department for Premier and Cabinet.
Thanks, Emily. So I guess the an example, if I can go to one to the value of these codes for us, is so we have obviously been involved in quarantining healthcare services, but also even just people that go to certain types of venues. Now, we have had, particularly for some of those types of venues, substantial delays in the time when we actually get to have the information about when people were there. When we get that information, we have problems of it being incomplete. We can be missing dates, for example, the critical information that we need, and particularly contact numbers to reach people. Any 2 or 3 day delay means that we've basically got people in the community who might not be aware that they've been exposed. They could already be infectious before we even get to reach them. So for us, the most important part of the QR code is that it allows us to have speed in getting the information that we need to identify who's been exposed or not. And it also allows us to define people who are not exposed. We had one of the groups that we were dealing with where the information we had came as a day rather than the 2-hour period where there was exposure to a case. So we had to do a large amount of work to try and refine that list down, which, if that's the only thing we had to do, would not be much of an issue. But in the event of a large outbreak with multiple, with thousands of people in the same situation, it really was difficult for us. So the most important thing from this sort of contact tracing and trying to stamp out an infection is really to get onto things as quickly as is possible. And we really need to do that within 24 hours of notification of the case. So firstly, the QR code stuff will give us instant information. And at the moment, we're waiting days for some types of information, but also it'll be more accurate, which will also help us in our reaching out to people.
Thanks, Katina. And we, I know we talked a lot about the incubation time and the length of the cycle, particularly with this cluster. I mean, particularly genome sequencing probably has helped with that, in the sense that we have only had the one linkage back to the genome sequencing with no international cases in between. But we've had a question come through around, are we looking at the cycle times, or is it really around the genome sequencing that provides us that clue as to the incubation time?
So really, it's the cycle times where traditionally you take date of onset of symptom from one individual to the next person that they've passed it on to, but effectively you could make that be from the time of acquisition to the next person having the virus. We've certainly seen some cases in this cluster whereby a person is exposed one day, already infectious the next day, and gone on within 2 days of being symptomatic. So we've seen very rapid examples, and that's usually when there's, I guess, a high viral load and a lot of close contact. We've also seen ones that come out to 9 and 10 days. So it really does vary. I think it varies with, the host, but also the circumstances under which that person became infected. So yes, it can be very fast. And we certainly, within a week, had at least 2 generations pass in this outbreak.
Thanks, Katina. So yes, very important QR codes. And we've just had a question come through around, will GP records still be requested in the event of a positive case? We've had a few instances where we got the impression that people were pretending to scan. I've seen that too, actually, at the coffee shop. But due to their apprehension, just went through the motion without actually following through the check-in. So what are your thoughts on that, Katina? Would you still be requesting those details from the GP practice?
Look, I think that we would probably, not having had the experience of using this I think what we would be doing is look to verify. So we would be asking, and the only people who can do that for us is the GP practice. I mean, we also know that, for example, when one person scans in, they could be representing 3 or 4 other people. And so it's by no means going to be a perfect information source. But what it will do is allow us to say, well, we know this one person was there, and then we kind of ask around that person who else may have been there. I think, though, in the event of something in a GP practice where we were very worried about transmission, we would be needing to verify, and so we would also look to the sort of information that we would ask of you now.
Thanks, Katina. I'll now hand over to you, Chris, to give us a bit of an update on the AMA general practice relevant issues and lots of really important things. I'm particularly interested in the COVID-19 vaccine, Chris, so just flagging that with you now, and I'm sure many GPs will be as well. Okay,
sure. Look, so I'll just quickly talk about Tele Health. AMA President met Greg Hunt, I think it was last week, and there was an announcement that it's definitely occurring. So they've pitched on that Tele Health will occur. However, the actual form is still not fully agreed on, but it definitely will occur. And there is a developing agreement about how it will continue. And I suspect what will happen is it will continue to form similar to the way it is now, except for the fact that there will be the requirement within general practice for some sort of nomination to be linked to that. And I think that's the general sort of way it's going, so that it becomes used as a tool, not the main form of producing of consulting with patients, and really not facilitating sort of a new industry which basically doesn't which just uses telehealth to provide care, because that, as we know, I think for all of us, that you do need to get the balance, and it is a tool, not the only way of providing care. Second thing is electronic prescribing. So electronic prescribing has launched. Now, for many of you, it may not have actually taken the jump, but look, it has started in South Australia, and it's actually gone really smoothly. And I kind of say thank you particularly, and I think I've seen Helen Stone on the list there, but Helen from the Pharmaceutical Society, but also from the Guild and the PHN and SA Health. Everybody's been, and the ADHA, everybody's been working really well here, and it's been the smoothest launch of anywhere. The main thing, I think, is to get to the ADHA site and sort of look up what you need. And the other thing is really to work with your local pharmacy, so that the first time you do it, that you don't leave your patient in the lurch if the pharmacy isn't quite ready. But there is actually quite a high uptake at the moment. And look, if it's not today, hopefully in the next few weeks that will happen. But I think it's been a very, very smooth start relative to other places. And don't be discouraged early on. At the moment, my understanding is it's over 1 million scripts have actually been dispensed by the token model already, but mainly in Victoria, which is way, way ahead of schedule. So it is actually, it's taking off, and it'll be a hell of a lot better than having to hand something over to your receptionist to have to fax to somebody and then send it off by snail mail. So look, please consider that. Now, and if you need some help, contact the PHN, who can give you some support with that. The COVID vaccine, which has really been the big topical thing. Look, I'm not an expert in this area, but I've been quite amazed about the progress in this area. I think, having been somewhat pessimistic about whether we'd ever have a COVID vaccine, it has been quite extraordinary, the developments in the last month or two, and the great statistics that we've had from the results from the trials so far for both the Pfizer, Mrna, and also the AstraZeneca vaccines. So look, at the moment, I'm not sure whether you may or may not be aware, the Fisa vaccine is the one which has had the most discussion because it's been released for emergency use in the UK. They have actually done a lot of the pre-reading and their approval of the vaccine, and for Australia it's great as well. We get to learn about the difficulties of getting out this vaccine, because this vaccine it's an mRNA vaccine. What it is essentially is it's a small fragment of mRNA, which a genetic sequence, which gives instructions for the production of the spike protein, as I recall. And so initially, essentially what happens is that this vaccine is injected into the arm. It enters the cells, particularly of the arm muscles, goes into the cells, and essentially gets your cells to start making the spike protein, which your body then feels that it's foreign body and develops an immune response to. And the studies show at this stage, the initial trials showed something in the order of 95% effectiveness. So what that meant was essentially that it was the prevention of disease, of symptoms. There's the data on whether it actually prevents transmissibility or whether there are people asymptomatic who don't become sick but can still transmit it is still not clear, and there's a paucity of data in that area. But that's this vaccine. It's called the Fisa BioNTech vaccine. It's an mRNA vaccine. The problem with it is that it's a very fragile vaccine which has to be frozen at -70 and transported in that way. And once it gets defrosted, it can only be it has to be dispensed in administered in a very short period of time, within days of defrosting. So there are significant issues with that. The AstraZeneca vaccine, which is essentially a similar sort of situation, except basically it's attached to an adenovirus, a chimpanzee adenovirus, which is then injected, and this adenovirus, which is obviously produces colds, something similar to cold, allows the genetic sequence to enter your cells and therefore does the same thing. That one is something that could be produced in Australia as distinct from the mRNA vaccine, and it is something which is a lot cheaper as well and doesn't have to be frozen at -70. It can be held at normal temperatures that we're used to. So that's going to be the interesting thing. The variability of cost is, I understand, the mRNA vaccine, the Pfizer one's in the order of about $40 or $50 a dose. The AstraZeneca is going to be something in the order of around about under $10 a dose. It's going to be easier to get out and easier to manufacture in Australia. We've already started manufacturing that vaccine, and we will be able to manufacture that in Australia. There's a couple of other vaccines which are out there, which are the Mrna Vaccine, and a couple of which is similar to the Pfizer vaccine, mRNA vaccine. And then there's a couple of ones like the University of Queensland and the Novavax vaccine, which you may hear a bit later. They're a little bit behind in terms of the development, but they are essentially a protein vaccine. So they essentially are the protein part of the essentially part of the virus, which is manufactured, which will then produce an immune response once it's injected. So they're coming along a little bit later. But we'll have a suite of vaccines, and I think at the moment there's still on this ATAGI group, it's called, it's a federal government ATAGI group, which is trying to work out a whole number of things about which vaccines and which situations the priority, and also the how to get it out there. And certainly I'll be representing general practice in that area. So there's a lot going on in deciding which vaccine. Now, in terms of the timeline, now my understanding is that, for example, the Pfizer vaccine, it's been quoted that the Therapeutic Goods Administration is currently doing its assessment process, and we may be looking at a approval around about the end of January, with a thought that we'll be able to start vaccinating in March. Now, obviously, that's the idea at the moment. The normal process for approving vaccine through the Therapeutic Goods Administration is normally 9 months. Now, you'll be wondering how they're going to get away with it between now and January. Essentially, the Therapeutic Goods Administration have spoken to us and explained that normally it's 9 months, but it's usually a resourcing issue. So what they're going to do now is essentially concertina down the approval process to a 3-month process, where they'll be doing all the steps in parallel rather than and putting a lot of resources into it because of its urgency. So they won't be skipping the normal processes in approving this vaccine. So just that's the assurance we've had. Now, obviously, we'll be watching for that, but that's to give you an idea of what is happening as far as the approval process and why it will be happening quickly. Now, the next thing I was just going to talk about is about prioritisation of the vaccines. Look, at the moment, there is work in that area to determine who's going to get it first. But to give you an idea, again, getting back to the point that the Fisa vaccine, the studies are really about whether you get sick. And at the moment, there is not enough data about whether it can actually stop transmission through the community, although it probably can. And even if you did, you'd have to immunise a very large proportion of the population to be able to develop that herd immunity. So in the UK, there's a independent committee which has decided, and they've quite rightly developed an order of who's going to get it, which is the highest value is the residents and staff within an aged care facility. Below that is those over 80 and frontline health workers who are most likely to be exposed to the virus. And then below that, it goes down by age and vulnerable individuals, and then it goes further and further down. So there's quite an order of play, and it's basically because the first aim will be to protect those at highest risk rather than trying to develop a sort of a herd immunity. Although in aged care facilities, obviously, if you can immunise both all the residents and all the staff, then you minimise the risk that there will be transmission within a facility like that. So that's the thinking behind it, and so you'll start to see some of that coming out at some stage. Who will give it? Now, look, certainly from the AMA, we've been promoting the fact that general practice and primary care should be very much a part of that. We've done such a good job in the past in terms of things like the flu vaccine. Having said that, I think you will understand this issue about the Fisa vaccine. There are logistical problems about this. So even Emily and I today have been having a little bit of a few texts talking about the logistics of that issue. But certainly the AstraZeneca will be a lot easier because it'll be much more similar in terms of storage as the flu vaccines and the other vaccines that we're used to giving. So yeah, there are logistical issues. The other thing is that there's going to be this is going to have to be a lot tighter than the flu shots, because there's going to be issues about making sure that consent, which I'll discuss with you in a second, that we can't, we're going to have to immunise a lot of people in a COVID safe manner. The logistics of this, trying to get 20+ million people potentially immunised over a period of time is going to be huge. And one of the things that's going to have to happen is that we're going to have to be really tight with recording of the vaccinations, because most of them are going to need 2 shots, for example. And so the logistics of this is we're going to have to be really tight with things like the actual numbers that we put in the AIR, for example. And even this week, I've had a talk with the Australian Digital Health Agency about the logistics of making sure this is as tight as possible, so we can do it as easy as possible. Because we don't want, for example, barcode. You know how hard it is to get certain batch numbers in there and how messy it is. We're going to have to make a concerted effort to get this as tight as possible, as quickly as possible. So I'm fully aware about the logistics of it, which leads on to the last issue about consent and indemnity. Now, the indemnity is going to be similar once it's approved, going to be similar to the normal vaccinations, but we said because this is a new vaccine, discussions are beginning about the issue of making sure that the consenting process, that we can provide information to all our patients so that they, and this includes individuals that may not have high health literacy, provide it in a manner which ideally happens before they even come to get the vaccination, that they have all the information, and that we feel that they can be they are providing informed consent before we give them the vaccinations. Because obviously, partly because there'll be so many, but also because we'll have to provide it in a COVID safe manner. We can't have a situation where we're sitting down there for 15 minutes going through the information to every single individual. It won't allow us to do that. So fully aware about the logistics of this, and there's a lot of work looking at that consent side of things, partly from the point of view of making it sure that it's smooth, but also to make sure that we can be assured that individuals are provided with the information that's required for them to provide informed consent, because it's a matter of our indemnity as well. Now, some of the options that are being considered are some sort of online consent model, so that people give consent when they come to see us. But that's the sort of thing that we'll be have to be considered. So that's all I have to say about vaccines. But look, it's a very topical issue, and it's a big issue, and I'm, certainly there are a lot of logistics associated with this. So just hang in there. But Australia's in a great position to be able to do this properly and learn what happens overseas before we give out the vaccinations. Can I just finally say some thank yous? Look, we're coming up to Christmas, and look, the people on this, like Tom and Katina and Emily and all these people. Look, I've actually had a chance to, I've seen how hard they've worked. You got to thank these people. They've done such an amazing job. And one of the great things is that in South Australia that we actually have all worked together. Now, I know there's been a bit of, let's be frank, a bit of narkiness about the vaccines, and it's a bit. There's some, many of us were upset about the vaccine. The mask issue. Sorry, but look, what I can say to you is that they have been extremely responsive. It has been very difficult. I have seen the magnitude of the decision making that has occurred and the level of decision making and how hard they had to work. And I think Chris McGowan, the CEO of SA Health, was in Daily quoting that he said that it's like trying to fly a plane while building a plane while flying it at the same time, which I think, having spoken to everybody, I think it has been a bit like that, and they've done such a great job overall. And I think the flip side of that is, for all of you out there, you've all played your part in this, and I think that's been really good. So you've stayed really patient, and so thank you to all of you. It's been really, really important. And Emily's done such a great job, and I keep on saying that she's really blown the flag for general practice and primary care. So we should all be thanking her. She's really brought that sort of external view out back into SA Health, which is sometimes needed. And I can say that Emily can't. So finally, my final word is then that really, please remember, patients with symptoms must have a COVID test. And I was a bit naughty and put up a tweet, a link to a tweet, because I did actually take my daughter. I had to drag her out in the morning to go to get a COVID test, and got one myself. And can I say to you, I had it at 9 o'clock, Tom, and I got the result at 7:25 that evening. So that was that time frame. That was actually just under 10 hours. So quite very impressive. So I was a bit shocked about how quickly it came along. So it is actually for true. And I was incredibly proud of, I was at the repat, and I was incredibly proud of the efforts down there. It was so well done, and everybody was so polite. So very well done to everybody here. I think we can complain about the little bits and pieces that have gone on, but I think we have to look at the whole. And so thanks to everybody for doing their part in all this.
Thanks, Chris. That's very kind words that you've said, and I think we all need to say a very big thank you to you as well. And I know that just the update you gave us on the COVID vaccine then, and I know you're representing general practice in the AMA on the ATAGI committee. So it's just fantastic to see all the work that you've done and all your early media calls and up on Sunrise and the Today Show and all of those places. So we're just so grateful, Chris, for everything you've been doing, particularly pushing the general practice message is so important. Look, I think that kind of brings us to the end now of where we were going to head with this webinar this evening. I know we've still got a few questions that have come in about the vaccine. So if you're happy to answer a few more, Chris, that would be great, or others as well. I know, Katina, you've got quite a lot of knowledge in this space as well. Look, just in terms of the vaccine, we've had a question here. If we're looking to produce the Pfizer vaccine in SA, will that be our preferred vaccine, or are we still contemplating weighing up using the AstraZeneca vaccine?
I don't think we can't make the mRNA vaccine. So the Pfizer and the Moderna, at this moment in time, we don't have the technology to actually make those. So they'll have to come from overseas, which is in itself a huge logistical issue. At the moment, we're signed up for, I think, 20 million doses of the Pfizer vaccine, which is 10 million. I think it's something like that. It might be 10 million and 5. So it's not. It's only going to be part of the solution at this point. It's early stage, obviously. But the AstraZeneca one is going to be a lot easier to deal with, and that is being manufactured already, as I gather, in Australia. So that one is actually potentially ready to go. I know that the studies on that were initially that it prevented 67%, I think, of people getting sick with the 2 doses. But interestingly, there was a slight slip up during the actual trial, and they actually gave a half dose to quite a number of, about two or 3,000 of their participants, and they found that those people had a 90+% protection from symptoms. Now, the reason for this is that this is an adenovirus. This is piggybacking on an adenovirus, and the theory is that you become immune to the adenovirus as you have more shots. So the issue with the AstraZeneca is that you can't continue to have shots forever because you become more immune. So therefore, you kill the actual piggyback, the thing you're piggybacking off before you can get into your body. So the thing is that that does make sense that the half dose and then the full dose as a second dose actually does make sense. Now, so yeah, look, so the actual theory, the numbers could be almost as good for the AstraZeneca. The other thing about it is that the AstraZeneca does maybe have a little bit more data and transmissibility, although that's not 100% clear, that it might be more helpful in that area. But so despite the fact that, you know, the numbers look fantastic for the 2 mRNA vaccines, it may be in fact that the AstraZeneca might just be as good.
Thanks, Chris. And we are really looking at how we'll roll this out. I think we're doing a lot of work here at SA Health currently, working with the Commonwealth around the rollout and a rollout plan, and for general practice to hopefully play a very big part in that, but also utilising existing primary care infrastructure that's already there, rather than looking at mass new models of care that perhaps don't utilise our fantastic staff and workforce that we already have here. So I just wanted to leave it there. I thank you so much to everyone, and particularly to you, Tom, Katina and Chris, for coming with me on this journey for these webinars this year. Hopefully this will be our last webinar before Christmas and we won't have any further cases. Would be fantastic news. Just our international travellers just bubbling along in our Medi hotels, in our revamped Medi hotel system. And a really big thank you to everyone who's made this possible, particularly to Adelaide PHN and to Crystal, who's been very supportive and helped us get these webinars together and upload them then onto the website in case you're unable to join us at 6 p.m. at night and you have a life at home like many of us do and we've given up as part of COVID. But a really big thank you to the AMA, to Chris for coming along to all of our webinars, to Tom, you've just been amazing. Tom, SA Pathology has done a phenomenal job, and particularly all of the clinics that have been set up and the rapid processing, genomic sequencing, serology that's been, the list just goes on and on and on. And Katina, of course, the amazing work that you've been doing with the parafill cluster. Look, I really believe the whole success of this cluster has actually come down to Katina bringing in incredible insight, strategic thinking into this space, and her incredible knowledge and background into the COVID system response. So just phenomenal work. So I think we have a lot to be very thankful to for Katina's work in this space. So we'll leave it there, and thank you so much for joining us this evening. This webinar will be available online, and hopefully you'll have a lovely Christmas, and fingers crossed, Tom, we don't have any of those Christmas Eve cases that you mentioned earlier.
Thanks, Emily.
Thanks, Emily.
Thanks, everyone.
No.